Good afternoon and welcome, everyone. Thank you so much for joining us today. I'm Samantha Watson, and I am the Director of Member and Partner Services for the Florida Association of ACOs. We are excited for this opportunity to present to you the next installment of our webinar series, What's Hidden in Your Claims Data Could Save You Thousands, presented by Ceresti Health. Before we get started, I'd like to go over a few items so you know how to participate in today's event. You will see a user control panel on your computer desktop. You can listen in via your computer speakers, or if you would prefer to join over the phone, just select the arrow above the news button and dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenters by typing your questions into the questions tab. You may send in your questions at any time during this presentation, as we will collect them and address them during the Q&A session at the end of today's presentation. With that, I'm going to turn our presentation over to Dirk.
Terrific. Thanks a lot, Samantha. Thanks, everybody, for joining. And hopefully today is a better day than when we had this scheduled originally, which was when the hurricane hit parts of Florida. So I hope everybody's doing okay. It's my pleasure to welcome you to this webinar. I'd like to start by asking our panelists to introduce themselves. I'm going to actually share my screen first, though. Can you guys see that okay? Just looking for a confirmation.
Yes, Dirk.
Okay, thank you. So this is a group of our panelists. Maybe we'll start with Dr. Asner, and we'll go down the list from left to right, and then I'll go last, and then we can just jump right into it. So Bart, if you wouldn't mind going first.
Thanks, Dirk. Hello, everybody. My name is Bart Asner. I'm a primary care physician. I, as it shows on the screen, was the CEO and founder of Monarch Healthcare, an IPA in Southern California that cared for well north of 100,000 patients, primarily in global risk. And I also had the honor of twice serving as chair of APG, America's Physician Groups, the trade association for groups that were involved in risk.
Thank you, Bart. John?
Hi, everyone. Thanks for joining today. My name is John Mach. I'm the Chief Medical Officer for Ceresti. I'm a geriatrician and spent 10 years doing clinical work in a multidisciplinary dementia clinic. Then I spent the next almost 35 years working in value-based care settings, both from a health plan and a provider standpoint, almost entirely for high-risk special needs folks. And then lastly, I'm the chair of the John A. Harper Foundation Board of Trustees, which is the oldest and largest private funded geriatric research in the country.
Terrific. Nicole?
Hi, everyone. My name is Nicole McPherson, and I'm the Director of Coaching Services here at Ceresti. I've been here 9 years now and run our coaching team and have had the pleasure of coaching many caregivers through our program.
Great. And then my name is Dirk Soenksen. I'm one of the co-founders of Ceresti. I'm the CEO, kind of an entrepreneur at heart. I've always been attracted to startups and, have built a couple companies in the medical device and now healthcare services space. Really excited for this webinar. The format we will follow is I will give an approximately 8-minute presentation to sort of set the stage for what hopefully will be interesting and provocative information, and then we'll move to a panel discussion where we'll dissect some of that. For those who joined late, you can answer, you can put your questions into the chat and they'll be either answered directly or we'll save them for the end. So let me move ahead and kind of at least give you a little bit of overview about who Ceresti is. You may or may not have heard of our company. We're a dementia care provider that has really developed a model of care that can improve patient outcomes, but also reduce total costs of care. You'll see us talking about the importance of enabling the family caregiver and the unique ability of the caregiver to detect a change in the patient's condition, and how through a tech-enabled monitoring model, we can achieve really remarkable outcomes. It's a turnkey solution. We have clinical studies that can validate our ability to reduce cost savings. We primarily operate in Medicare Advantage as a specialty care provider. And then we are a participant in the GUIDE model. And part of the, maybe the mystique around the title is that if you combine our model of care with GUIDE, there's a tremendous opportunity for ACOs to actually, realize additional shared savings. So why would somebody partner with Ceresti for dementia care? It's a big problem. So dementia is a big problem. It actually requires caregiver engagement. We'll say more about this, but this is really one of the key things required to be successful and better outcomes. The CMS guide model, again, we're a participant in that, establishes dementia as a national priority. And this is a problem that as the population ages and primary care physicians will continue to retire and there might be a shortage, the problem gets worse. There's also 50% of people with dementia are not currently diagnosed. There are solutions that exist that can achieve significant cost savings. And it's actually fairly straightforward to determine, who caused those savings. So attribution is straightforward. And then we as a company, we can drive enrollment, we can get people into the program, and we can provide a framework for realizing shared savings. We will say more about this, but this is some of the reasons why people partner with us. If you look at Medicare data and you just look at people with dementia and Medicare, you sort of realize dementia is not typically prioritized. And we're gonna actually ask Bart and John to tell us about their experiences, but it's not typically prioritized, probably because people don't believe they're effective solutions. The cost of dementia many times invisible because the conditions sort of mask the symptoms that you observe are not always clear that they're attributable to dementia. Claims analysis can play an impact, but the fundamental root cause for all the, let's say, poor outcomes is that people with dementia can't self-manage. They can't participate in traditional programs. The costs are largely driven by unmanaged chronic conditions, infections, and falls. And this is why 42% of people with dementia have more than 5 chronic conditions. So the family caregiver can help, but you got to be able to engage the caregiver to realize the benefit of engaging the caregiver. So ACOs and payers, they don't really have the tools to engage family caregivers. So this is really, I think, a unique opportunity to look at a disease condition for that reason. So in dementia, there's a link here. People with dementia drive 27% of all hospitalizations, 21% of total cost of care. Interestingly enough, if you look in a fee-for-service data set, as is shown here, and you put all the people that have a diagnosis of dementia in one bucket, it's the second most costly condition in Medicare. Most of you probably don't believe that, but again, this is sort of the nuance of looking in claims data. So first of all, it's a very expensive condition, so it's an ideal target for cost savings. Our suggestion is to put all these folks with dementia into a specialized clinical program, and that exists. The guide model sort of sets a standard, and if you can enable the caregiver, to detect the changing condition, to engage the healthcare system while you're supporting them, if you can reduce harm by preventing falls and addressing med reconciliation challenges, you can really get better outcomes. And as evidence, I sort of offer a study that Ceresti did, where what you see here is hospitalizations per 1,000 on the vertical axis. The purple bar highlights the hospitalization rate when dementia is comorbid with, let's say, diabetes or COPD or CHF. The light blue is what the hospitalization looks like without dementia. The purple to light blue multiplier highlights patient can't self-manage, doesn't know how to engage the healthcare system, and the caregiver doesn't know what to do. The green bar highlights what we achieved in this population through the Ceresti program. You can see that we had a fair amount of success in extinguishing a lot of these avoidable hospitalizations. Let me just briefly now highlight the guide model, because this is an important piece of the value proposition for accountable care organizations. In 2023, CMS announced a new guide model. It was aimed at reducing avoidable hospitalizations and fragmentation of care and so forth. It's an 8-year model. It establishes a standard for dementia care. It requires the inclusion of the family caregiver. The participant, so this would be Ceresti in this case, can submit a claim to CMS, right, for a monthly dementia care management fee. There is a respite benefit. I see that that got sort of misspelled here, so I'm just going to retype it here. There's an annual respite benefit. And then, importantly, any eligible fee-for-service beneficiary can align with any guide provider. So that's an important consideration. Anybody that is a guide participant or guide provider can go to any of your patients and they can align. And you'll see that there are some reasons why maybe that's not ideal for an ACO. Medicare Advantage members are not eligible. So let me take maybe another minute and just highlight the opportunity for an ACO. So again, this is a model where somebody like Ceresti or any guide participant can align a dementia patient with a guide model, and then CMS will pay the fees. Right? So to an ACO, there's an opportunity to partner with a company like Ceresti, where the ACO retains 100% of the cost savings. So we unlock about $6,000 to $7,000 per patient in cost savings. And to the ACO, there are no out-of-pocket fees, right? In part because CMS pays our fees. So we align the dementia patients with the guide model, and we retain 100% of the guide payment that covers our costs. The ACO gets the additional cost savings. Now, the guide payments count into medical expenditures, and this is now true for both MSSP and REACH ACOs, right? So the medical expenditures increase, where if you don't reduce costs by a similar amount, right, you would actually be in a worse position. So we actually guarantee that our cost savings exceed the magnitude of the guide payments. And on the right-hand side, you see kind of the possible net shared savings that could be earned, let's say, through the end of 2026, if you had an ACO with about 1,000 dementia patients. And that might be an ACO with 15,000 patients with a prevalence of dementia of between 6 and 7%. So this is maybe more the average ACO. And if your ACO had 30,000 patients, you could double these numbers. If it had less, you could prorate them, right? But essentially, if you're in the enhanced track of MSSP, you could realize an extra $1.2 million in net shared savings by the end of 2026. If you're in REACH and in the global track, it's as much as $1.6 million. So it's significant. If you divide it by the total number of patients and you sort of compare that to your existing savings, it's probably on the order of 20% of what you're currently realizing in net shared savings. So definitely a meaningful number. Okay, so I timed myself and I actually did a good job keeping this on track. So what I'd like to do now is I'd like to pivot to a panel discussion. So I will stop the sharing, right? And my first question, wait for it, I have to unpack the envelope here. My first question is really aimed at getting feedback from John and Bart, starting with Bart. Like, what's your reaction to dementia being a top cost driver? I mean, you guys have been doing this a long time, so tell me what your reaction was with that.
Yeah, my first reaction was, huh? I don't believe it. It just can't possibly be. Now, Monarch Healthcare did take global risk on seniors, but also was a pioneer ACO. We are amongst the first ACOs in the country. And we were focused on reducing healthcare costs. That was how we would obviously thrive. And we had very sophisticated analytic systems. We looked at all the usual suspects with CHF and COPD, et cetera. And I was always asking my clinical team, where else can we find savings? Where else can we find savings? And frankly, dementia never came up. So when I saw your numbers, Dirk, I frankly was astonished. First, I didn't believe it. And then as we've talked more about it, I go, okay, I now get it. We just missed the boat. We did not ever see dementia come up as an opportunity for reducing our costs. And as an ACO, it's all about reducing our costs to get shared savings and reducing admissions. The opportunity is enormous. And frankly, we missed the boat. But now that we understand this, I would absolutely be focusing on dementia.
And John, I mean, you have more health plan experience, so same story, different story? You're on mute.
Pretty much the same story, embarrassingly so, given I'm a geriatrician and been working on this for a long time. I think it's a function, so just like Bart, really sophisticated analytics teams, always looking for opportunities, pouring through the data repeatedly, several different organizations, none of which came up with dementia. And I think a couple of things are going on. First of all, dementia is a marker, but not the cause of the increased, direct cause of the increased cost and the hospitalization rates. And we'll talk about that in a minute. And I think it's the way the claims are pulled, frankly, Dirk. I think unless you're looking in deep into the fields and have dementia in there, and because it's only coded on a rare event in an office visit, and certainly rarely in a hospital visit, do I think that's the reason it's just been invisible? And ironically, my friends in academia were sending me papers saying dementia is an expensive condition. And I mean, even CMS has changed their mind about this. Early on, when risk adjustment first came out, dementia was zeroed out because they thought their data told them it had no impact. But now that they've looked at it, they've come up with the guide program. So I think we're all getting on board. We're all late to the party, but it does represent a big opportunity.
No, I think what you said, John, use the word invisible. It's an invisible diagnosis. And that, as I look back on it, is one of the reasons that we didn't really identify these patients and identify the opportunities for cost savings. It's a hard diagnosis for primary care doctors to make. They don't like having to care for dementia patients because it's difficult and complicated. So I think there are multiple reasons why we didn't see dementia identified and diagnosed, and therefore never really connected that with these major disease states that were so much worse in dementia patients.
Yeah, you might have to go back several years in claims to try to find it. But, again, it's still maybe 40 to 50% underdiagnosed, but there are enough of them diagnosed now, and there's such a cost driver that it behooves ACOs to take a direct look.
Yeah. So John and Bart, but maybe starting with you, John. It's a big cost. Now, typically, maybe one of the reasons people haven't prioritized is because they said, look, even if I knew it was a big cost, what would I do? Okay. So in your experience, what are the drivers of costs? Like, what are the biggest drivers that are contributing to the high healthcare costs for people with dementia?
Yeah, across all high-risk populations, dementia included, it's always hospitalizations, excessive hospitalizations. And whether you look at 5+ chronic conditions or dementia-related care, it's really the hospitalization. So when you look at ACSC, the ambulatory care sensitive condition component of that, which is now a recognized opportunity or way to look at opportunity in hospitalizations, it's very high in these populations. So it's all about hospitalization, Dirk.
And Bart, you kind of mentioned before that these patients are very difficult to manage. Of course, if they go into the hospital, right, they're even more difficult to manage for primary care physicians.
Yeah, it really is a problem for, first of all, managing the conditions, because they come to the hospital a lot sicker because their problems are not identified as early as they should be. And managing and caring for dementia patients in the hospital is obviously multiples of complexity because of the difficulty communicating with them. And then I really worry about when they go home. If the caregiver is not engaged and educated, who's really making sure those patients are now taking the right medicines, because they may have had different medicines in the hospital than they were taking at home. They need follow-up appointments. Are their conditions changing while they're at home, and therefore they end up back in the hospital because they weren't really transitioning out of the hospital correctly and well? So it's a very complicated situation. And we all know that hospitalizations are the main drivers of cost for all of our patients. And the key is to reduce the hospital admissions first and foremost. And that means understanding these dementia patients in ways that we historically have not. And then when they're in the hospital, making sure that we can communicate with whoever the caregiver is going to be to make sure they're cared for well when they go home.
Yeah, I'd like to follow on a couple of things that Bart said early on. He said that the patients might be sicker as they present to the emergency room or to the doctor because of things aren't recognized right away. Dementia is a masking of typical symptoms that you would get in an infection or other things. So it is harder to recognize. So people stew and kind of percolate and get sicker. I think that is a valid approach. And then the disruptive nature of the hospitalizations, they're so often have to be restrained, either chemically or physically. They don't eat, they get malnourished. All the nursing homes say all their pressure ulcers come from the hospital, not from the nursing home. So, and then as we know, each hospitalization is a stepwise decline. For people, they don't recover, and it's twice as much caregiver burden when they come out.
So for all those reasons, we need to keep those patients, like all patients, out of the hospital. Obviously, we'll have cost savings if we do that. But in terms of quality of care, keeping people from getting to the ER and therefore getting admitted to the hospital is really key. If a dementia patient ends up in the ER, the chances are almost 100% they're going to be admitted. And
Right.
that's a problem for everybody, including, of course, from our point of view, in terms of cost savings and quality of care.
So John, connect the dots for us here. So we've talked about the high cost of dementia. We said it's hospitalizations that are driving it, and we said we want to keep people out of the hospital. But what are the levers that have the biggest impact in your experience on reducing hospitalizations?
Well, the early recognition, I think, is probably the principal thing. And we in a couple of places, my care management organization looked backwards. So if they saw hospitalization, they'd look retrospectively at what was going on. And they almost always found symptoms or indicators 24, 48, 70, probably 72 hours that something was different. Now, the challenge with different is it could be different in many ways. So the key is to know that they're not the same as baseline, that they've made a substantive change. And it could be non-specific. It could be not sleeping well, poor appetite, agitation, both either somnolence or agitation. You could get both behaviors, and just something's off about them. And one of the fun things, and we'll talk about that, is caregivers are the first to recognize this. So getting that early warning system, if you will, in place via the caregiver by training and education and empowerment of the caregiver, and then the opportunity to act on, because as you mentioned earlier, both Dirk and Bart, that these are infections, medication misadventures, falls, other things that that are treatable, and we can see that in the data.
Okay, so it sounds like, and I think you've also shared with me in the past, John, that when you ran a dementia clinic, you realized something about the value of the caregiver. Can you share that?
Yeah, it was there's probably two kind of phases. There's the initial diagnosis, and how challenging that is for both the patient and the caregiver in terms of the initial diagnosis, trying to understand exactly what's going on at a brain level, imaging, behavior issues sometimes, are there reversible causes? That's a whole event. That's very physician, neurology, geriatric psychiatry, geriatrics driven. But and again, 10 years in a dementia clinic, it's the longitudinal relationship that with a caregiver that is almost always either social worker or nurse led, for the understanding both social determinants, the clinical resources in the community, but also this subtlety around change of condition and when to act on that and when you don't have to act on it, and just key strategies about how to address that, which I'm sure Nicole's going to get into.
Okay, so now the question should be, how on earth do you detect a change of condition in the home? Because I mean, that's essentially what we're saying you have to do. So Nicole, can you give us a little bit of insights into how we do that by engaging family caregivers?
Yeah, excuse me, absolutely. So, of course, family caregivers are motivated to observe changes in their loved one's condition because of the personal, emotional, and of course, the financial investment that they have in the well-being of the person that they're caring for. So they're experiencing the immediate impact of their loved one's health firsthand. So their personal connection to their loved one drives a real strong sense of responsibility. And they're not only witnessing the progression of healthcare or health changes, but they're also actively involved in managing daily care. So through the Ceresti program, we empower those family caregivers with knowledge through education and support through coaching, and so that they are enabled to recognize this change in conditions early and take proactive action by engaging with the healthcare system before the situation really escalates to that critical need that we've been talking about here.
So it's through technology, right? So can you talk maybe about do they use a smartphone? How do they?
Yeah.
access
So through our
education?
program, we're sending them a tablet, and we provide a really great education that they are able to work through. It's really best practice based education, and they're supported through a coach through their whole time on the program.
So as part of the guide model, the coaches that Ceresti have are really filling the role of the care navigator, right? So tend to be social workers. They don't have to train. There's trust built, right? So I think maybe you can talk about the importance of the trust that the coach builds with the caregiver, so that they're actually willing to listen to us and share information with us.
Absolutely. So I think a lot of these family caregivers feel very alone. They feel very isolated. The burden is very heavy for the person that they're caring for. And so it's really important that our care navigators or coaches, as we call them, show up for these caregivers. I think one of the most important responses is that when a caregiver gives something, like a daily assessment, for example, maybe they've indicated something is wrong or a challenge, maybe a huge change in condition, like we're talking about, that their behavior is out of control for that person. Their coach is going to follow up with them. They are going to reach out. They are going to essentially be that lifeline for that caregiver who wouldn't have had something like that before. And in those moments of showing up and following up and being a voice of reason, maybe helping them make hard decisions, encouraging them to reach out to get these things addressed, I think that person sees, oh, I'm not doing this by myself. I have someone, I have a program that I can count on. And then from there, it's like they have this aha moment where they just kind of take off and the education becomes more relevant for them. They can see themselves, down the road being able to do this job, if you will, whereas they might have been doing that. It's a scary thing. We can help take the fear out of that by forming that relationship, but then, following up with a lot of knowledge, the skill and confidence to go forward.
Bart, so now you've become aware of dementia being expensive, right? You sort of have heard about the Ceresti program, or any program for that matter. What are some of your considerations as an ACO to think about, hey, how do I deploy this? Like, what's going through your mind? What are you trading off? What are your, what's your path?
Sure. I want to just first make a comment about what Nicole had to say. These caregivers are just wonderful people. I mean, I'm just so happy for the dementia patients that they have a caregiver. But to have that caregiver be engaged and empowered by the Ceresti program makes all the difference in the world. And Nicole pointed out much of that. I also think that it's important to understand that the changing conditions we're talking about are often going to the coaches, and the coaches help the caregiver understand whether it's serious or not. They're not going to be identifying a terribly serious condition 4 times a day that the doctors have to deal with. It's important to understand that this is a support system that will really help when a serious changing condition is noted early. So what was your question again, Dirk?
So the considerations for how you implement one of these.
Yeah. So when we were approached all the time by people who had programs to help solve our challenges with all high-risk conditions. And the key is, first and foremost, to understand and believe in the program that was being presented to us. And I have strong faith, of course, in Ceresti's program, or I wouldn't be here speaking with everybody. What is the cost of the program, and what benefit are we likely to get out of the program? These are financial decisions that we have to make as an organization. And I think that's always way high up on the list. We look at the people that are going to be performing the program, and can they work with our own teams? Because again, we have to connect the Ceresti people and the caregivers with our own clinical teams to make sure that we're working in a collaborative way. And of course, at the end of the day, a lot of things come down to cost. But if we can feel very confident that we're going to get a significant benefit in cost savings, as I do believe Ceresti offers, then engaging in a program like this makes excellent sense. We get a lot of people coming to us trying to sell us solutions. And the question is this solution real and productive, not producing an enormous burden of work for our people, taking a burden off, helping the primary care physician do a better job so that we can then refer patients early on, as John said, for the appropriate care that they need.
John, can you comment on the make or buy decision? Because I know in a health plan world that you have the capabilities to build it, but then sometimes you partner, sometimes you build it. So just kind of walk us through the calculus of that thinking relative to, let's say, a dementia program like this.
Well, even backing up from that a little bit, my question, are these people already enrolled in my programs? And the answer is no. So in complex care, and we looked at this, Dirk, at the Harvard Pilgrim study that we did, only a handful of the hundreds of people that needed this kind of care were actually enrolled in the complex care program, despite all the best efforts. The other ancillary thing I would mention is, people are big on high-tech remote monitoring. They're big on home visits. None of that is sufficient to capture the subtle changes in behavior, as Nicole mentioned, agitation, sleepiness, change of appetite. They're in either the frequency of the visits too infrequent, or you just don't have the sensitivity of your monitoring around that. So I think this is one of those things where you need a special program for. And there's only a handful of things that I think you do in the complex world, but this is one of them. And so I think that the novelty and the importance and the central role of the caregiver, way beyond just providing a list of community services or a monthly call or call me if you have any problems. It's much more in depth on training, support, empowerment, how to talk to a doctor. I'd be interested in Bart's opinion about, from a provider standpoint, is this beneficial? So when I was faced with, or we were faced with those kinds of things in a health plan world, we build or buy. And, for something that we were really excited about, we almost always looked at potential outsourcing for the speed of adoption and the expertise we could leverage that we would have to, it just takes too long to build ourselves, and we just don't know how to do it. Just enrolling these people is a novel approach. So that's different than your complex care program. So finding and enrolling them is special. So if you have a company, an organization that knows how to do this well, I got pretty excited about our sourcing, at least in the medium term.
Yeah.
Yeah, I agree with you, John. I don't think in this case we would have ever tried to build this internally. It made no sense. We knew so little about the dementia patients, the care, the empowerment of caregivers. It would have taken us so long to get there. And if we could find a partner who could do this well and jump right in and make a difference, especially in an ACO model where we're trying to get cost savings right now, it becomes a really easy decision. And you asked about how this impacts the primary care. I think this just makes it so much easier for our primary care doctors to have someone that they can count on and trust, from the coaches that Ceresti has in place to the now engaged, empowered, and more knowledgeable caregivers. It makes our life as primary care doctors much, much easier. We can provide better care, which is really what we want to do.
So I call this unburdening the primary care physician. And while I almost recognize the cost savings are important, but in discussions we've had with ACOs, the burden on the PCP is a consideration. So John, can you maybe just share your views on why a program like this should, what I would call, unburden the caregiver?
Yeah, well, the caregiver or the provider?
The provider, sorry, the provider.
Yeah. Well, it's just in my practice days, see a number of these folks, and when I was in the multidisciplinary dementia clinic, which was in the VA, which you can't, up until guide, you could not afford that. No provider could provide all those services. We had social workers and nurses and stuff to, therapists to work directly with the caregiver. The physicians, it's really optimizing your role in each of these when you're doing team care, and everybody understands that in ACO. So it was not optimal to try to leverage me solving for caregiver support issues around that. And in private practice, outside of the team, that just was a big source of frustration. I think on both parties, the caregiver and mine. I think, just not having the resources ready at hand. I didn't have the time necessarily, given the way clinics work. It was just pressure that I didn't, and it just professionally dissatisfying to not be able to address those things, knowing how much they contribute to the outcomes.
So Nicole, give us some examples of things that Ceresti supports caregivers with, or challenges that they have that, would maybe possibly go to the primary care physician, but that we sort of deal with. I know there's a whole bunch, right? From incontinence to wandering. I mean, just give us some examples of things that maybe somebody would take to their PCP that we just sort of take off the plate.
Right. Well, one of the most common that I kind of alluded to earlier is a caregiver might indicate through their tablet They might complete a daily assessment, which we ask each caregiver to complete, get a real window into what's happening with that person real time. But say I have read countless free responses in our daily assessment where they say, my mom just is not herself. I don't know who she is. She just was up all night, wasn't sleeping, total change in behavior. And a lot of the times these caregivers don't know to look for maybe an underlying condition like a urinary tract infection, because you wouldn't expect to present it that way. There's a lot of other physical symptoms that everyone knows to look for, but our coaches can reach out. And the really great thing is we can personalize a workflow on the tablet. We can assign certain education to say, hey, I want to educate you on what a urinary tract infection is, how that presents differently. And I want you to see if maybe that fits. And if we think we have something to be concerned about, this is how we address it. Reach out sooner than later. Let's get the urine tested. Let's rule this infection in or out, get it treated. And then the coach can then follow up and make sure that we're taking antibiotics, we're seeing a reduction in symptoms, and that things normalize out of that kind of crisis level. I mean, I could tell you so many different changes in condition that I've helped with. It could be a sudden fever out of nowhere. Sometimes I think people don't want to bother their doctors. They don't really want to kind of shake the boat or make any trouble for them, or but we can explain to them why it's important to do that. If we see something, let's catch it now, because we don't want it to get to that point where things are suddenly changing. We need to go to the ER quickly, and there's so many opportunities if you really establish, like we talked about earlier, a trusting relationship where you're going to follow up with that person and they get something out of it. They know how to almost be a detective going forward and how to respond appropriately. It's really exciting to see those moments and to help train and empower these people going forward.
I think the message that you're conveying is one of, as you said, Dirk, unburdening the primary care. Primary care doctors feel very overwhelmed these days, particularly from a lot of the administrative tasks they have. And if you have a patient in your practice that you can't communicate with, i.e. dementia patient, and don't really know what's going on because there isn't a caregiver who can help you understand, it just makes your day that much harder. And we don't need to burden primary care with a more difficult day. They already feel burdened, and in some cases really thinking, should I continue to be doing this as a primary care? So anything we can do to help our primary care feel, wow, this is really a better day. And all they want to do is help patients and get them better. And they need the information, and they need the information as quickly and clearly as possible. And that's what Ceresti is doing for my primary care doctors.
Yeah. Terrific. Let me shift the discussion back to the guide model. I want to reshare my slide on the guide model. Can you guys see this?
Yeah.
Still have this typo here for some reason. Okay. So I want to just review the slide, and then I'd like, John and Bart to maybe comment on the medical benefits of this and the implications for an ACO, right? But CMS did about a decade's worth of research. They stood up this program called GUIDE, which is an 8-year program. It establishes a standard, right? So you have to do things in 9 domains, including making a diagnosis, reconciling medications, offering, a 24/7 helpline, doing, helping with care coordination and everything else. Importantly, it requires that the caregiver be part of the care team. I think this is a huge recognition on the part of CMS that the caregiver plays the pivotal role that John, experienced when he was running his dementia clinic for a decade. So there's a payment, right, that compensates a company like Ceresti for providing these services. There's an annual respite benefit for qualified individuals, $2,500 a year. So that's potentially interesting. And again, any eligible Medicare beneficiary can align with any guide provider. So any ACO's patients could align with anybody that maybe the ACO has no relationship with. That's not necessarily ideal because those costs will be added and you have no guarantees that that participant will actually do anything that will reduce your medical costs. And then MA, Medicare Advantage members are not eligible. So just wanted to review this again, and then I'd like to go back, and John, and have you sort of just opine on what do you think of this model? What do you think of it from the perspective of improving patient care? And, what's your general opinion of the guide model?
Very positive. Again, it enables team-based care in a fee-for-service world, which was absent. And actually, you know, you could argue that it should be the Medicare Advantage world too, because those providers tend to get paid mostly on fee-for-service, not exclusively. So supporting this non-traditionally billable approach with a global payment, I'm a huge fan of. The model of care itself is derived directly from their study of evidence-based programs and components of evidence-based programs. Yes, a lot of these are black box-ish kinds of things, so they try to do their best job around kind of here are the key elements that seem to be related and at least correlated with better outcomes. I think they've done a good job. We'll see, you know, what they learned from this program. It's going to run quite a few years, and hopefully we can get better and innovate on the model as presently described. But I do think it covers all the bases. The one question I'd want to raise is the respite. You know, I think that's bold of CMS to put that respite in there. I think that's a direct acknowledgement to caregivers. What we don't know is the, you know, financial impact of a respite benefit on the overall cost. That's an open question still.
Yeah. Bart, from the ACO's perspective, most people I talk to in the ACO world don't know much about Guide or just becoming sort of familiar with Guide. What do you think the view, once people get a little bit more educated, what do you think their view will be of the Guide model?
You know, I think it's really important to understand that CMS has now made dementia a priority. I mean, it was not a priority for most of us. Let's face it. We had other things we spent our time and energy on. And I think that is really important. And it also focuses on the fact that there are things we can do for dementia patients that we didn't think about in the past. So I think it really helps us as an ACO to think differently about this. Now we're thinking differently about it. The Guide model is really pointing us to the fact that there are Guide providers like Ceresti and many others who can help. But I think it's really important to be thoughtful about who can really help us detect that change in condition so that we can have an impact on patient care and costs and outcomes. And not everybody can do that. I know lots of people got approved as Guide providers, but there really is a difference amongst those that can really make us more successful and those that are just kind of Guide model participants.
Yeah, terrific. So we're certainly excited to be a participant. As I mentioned, right, the relationship that we would form with an ACO is one where, you know, we basically get paid by CMS and the ACO gets all the shared savings, and the shared savings based on our guarantee are larger than the medical expenditures of that are added as a result of the Guide payment. So,
and you're talking about a no risk model for the ACO.
This is what we believe is true, right? I mean, so what's the risk? The risk is, well, the risk actually is that your dementia patients will align with somebody else. Your medical expenditures go up, and then you are writing a check to CMS because there's no cost savings, because there's no detection of a change in condition. But essentially, Bart, it is a no-risk model to an ACO, right? And a typical ACO, you know, as we talked about, depending on the size, but it's probably 20% of whatever you're getting now in shared savings. You could add that, you know, in one calendar year. I think 20% sounds significant.
Yeah, it is.
Yeah. So I want to turn to questions, but before we do, I want to kind of summarize what we heard here. So I'm not smart enough to memorize it, right? But I did write it down. So I'm going to sort of just read something sort of into the record sort of thing. If you listen to it, it'll be a nice summary of what we learned here. So first of all, thanks for the fantastic discussion. So what we heard here, that the real costs of dementia are invisible because of the masking of symptoms, right? That was really important. And then we also talked about the way claims data is pulled, having an impact on being able to make dementia more visible. We showed a data set, a 5% CMS sample, where dementia ended up being the second most expensive condition in Medicare. Again, this becomes apparent if you put all the patients with dementia into one bucket and you think of managing them in a special program, not as part of an existing program, because as John said, you know, people who are in CCM or other programs, if they have dementia, they're not going to be effectively engaged, and they're very few. We learned about the guide model, why it was launched, and how it's really intended to reduce hospitalizations in the face of an aging population. And as Bart said, CMS is sending the signal, dementia is a priority. You should care about this. We talked just about the multiplier effect, that people with dementia go to the hospital because of unmanaged chronic conditions, infections that are out of control, and falls, and how this inability to self-manage is the root cause. And then we talked about how a caregiver can really help with that by detecting a change in condition. So we talked about hospitalizations being the key driver. We talked again about the change in condition being the thing you have to do in the home in order to get that signal 2 or 3 days before what would otherwise end up being an ER visit. And we talked about the high likelihood, if you show up in the ER with dementia, that you are actually admitted to the hospital. Nicole sort of shared that the family caregiver is motivated, right? It's somebody who wants to help, who in most cases loves a person and says, teach me. That we have the benefit that we're not paying them, the CMS is not paying them, they have the benefit of respite that comes as part of the guide model. And so Nicole shared that this tablet-based approach that Ceresti has adopted allows a caregiver to access personalized education that is dynamically personalized in the moment, on which they can report what they observe in their loved one, which then leads to Ceresti taking care of most of the issues, but in a few cases, alerting the provider about an issue or nudging the caregiver to contact the provider. And then we talked about some of the considerations for ACOs, particularly about sort of thinking through the additional guide payment being added to medical expenditures, and how it might be valuable to work with somebody who can guarantee or can ensure that the cost savings will be higher than that. And then we just sort of talked about the guide model as a good start, and John sort of said, hey, everything about it seems good. And we know it's a new model, there will be learning, and we expect that over the 8 years of the model's program, right, the duration, that the model will be tweaked and optimized as you would expect for any organization that's doing this. So with that, we're at 10:47, so we're pretty much on time. I'd love to have some questions, to take some questions from the audience, and I don't know, Casey or Samantha, who's reading those out, but please fire away with some of the questions that have come in.
Sure, I'll take those. That was a great presentation, and we truly appreciate hearing about the Ceresti's guide program. So actually, one of the first questions I do have is, how does Ceresti's guide program impact the PCP with everything else they already have going on?
So Bart, this kind of goes back to the question about unburdening. So maybe we just kind of, go over that again.
Sure. So I think the PCPs are currently burdened by these complex patients who come into their office, and it takes a lot longer to get to the bottom of what's going on. They come in sicker than they should. The caregiver really isn't as helpful. And Ceresti's program does just the opposite. By engaging and educating the caregiver, having them work with the coaches from Ceresti, it makes the visit, when the visit does take place, a much more effective visit, shorter visit, getting to the point and getting the care done at that time that the patient needs. So I think it makes the life of a PCP easier. I made the point earlier that there really are very few times that the Ceresti coaches need to make a contact with a PCP. That's not like 3 times a day or anything that would burden the PCP. It's, in fact, it's just the opposite. By working with the caregivers to make sure that they understand the change in condition early on, we can avoid those complicated visits with the PCP.
Terrific. Thank you. Is there another question, Sam?
Yes. So question 2 I have is, how do guide payments impact an ACO's medical expenditures? And how does the respite payments impact expenditures?
Yeah, so the question is, and we've talked about it a little bit, and I think it's a good question, because there certainly was some lack of clarity in some of the early guides from CMS, but the guidance from CMS that we received just about 10 days ago is that the care management payment that CMS would pay to Ceresti for the dementia care program adds to the medical expenditures of an ACO. And it doesn't matter whether the ACO is an MSSP or a REACH ACO. So that's a little bit new. So beginning in 2025, medical expenditures will increase by an amount equal to the guide payments. The respite payment does not impact medical expenditures, right? So there's some, if you looked at the early guidance that suggested it did, but the latest answers that we've gotten from CMS is that the respite payment is excluded from medical expenditures, which makes sense based on John's argument that we don't even know if it saves any money, and the medical expenditures are. So and by the way, the typical sort of guide payment that we estimate, it's about $1,500 a year once you get going. It's $250 for the first 6 months, and then $150, so maybe $125 for 6 months. So between $1,500 and $2,000 a year will be the addition to medical expenditures as a result of the guide payment. Right. So if you're an ACO and you have 30% downside risk, if you don't save money, you're writing a check for 30% of $2,000 for every dementia patient to CMS. And my guess is nobody would be excited about that.
So what does Ceresti do to offset that, Dirk?
We guarantee that our cost savings. So if the payment is $2,000, right? Historically, we save $6,000-$7,000 per patient. So we guarantee that our cost savings, which are $6,000 to $7,000 per patient, will exceed the about $2,000 payment that come from guide. And then the additional $5,000 is attributed to that can add to cost savings for the ACO, right? So if we save $7, the guide payment is $2, there's $5 available. So if you're in global track of reach, you put all $5, to your bottom line. If you get 50% of that, you put $2,500 per patient to your bottom line. So it's meaningful even if you aren't in a global risk scenario. Okay, so keep going. We run out of time here.
Yeah, we'll go one more question. Can my ACO patients align with any guide provider, and how does that impact the ACO?
Yeah, so I'm going to answer that one, and happy to take some other comments. But the way this works is that any Medicare traditional fee-for-service patient can align with any guide provider in their sort of zip code. So CMS will send out, maybe already has sent out to some people, letters saying, if you happen to have dementia, and I think they're using ICD-10 codes, right? We have this guide model, and here are the providers in your region that offer the guide model, right? So if there's 1 or 2, you'll get a list of 1 or 2. If there's 10, you'll get a list of 10. And that patient that could be part of an ACO can sort of go to any one of these guide providers and say, hey, I'm interested in guide. So now the ACO could have some of their patients, probably unbeknownst to them, align with a guide participant, right? So what's good or bad about that? The good thing is that they're going to get an evidence-based program, right? They're unlikely going to have, unless it's Ceresti, the ability to detect a change in condition in the home. So the program probably won't save money, right? So what will then happen is that the expenditures will add to the ACO, right? Which is negative for the ACO. Of course, selfishly, the strategy we would advocate is make Ceresti your preferred partner and help us refer your patients so that you actually are proactively suggesting to your patients that they should align with Ceresti, because we're really purpose-built to support the primary care physician. We do not have providers that are part of our organization. We're not changing the care plan. All of the clinical work we're doing through partnerships, but we're purpose-built to support the primary care physician. We're non-threatening. We minimize fragmentation of care because we want to feed all the information right back to the primary care physician. So obviously we'd love for folks to think of us as a partner, but the risk that any ACO has is that some of the other folks that are trying to build capabilities nationwide are going to make partnerships with an Alzheimer's association or with a church or with a senior living facility, and some of your guide patients will get aligned unless you proactively steer them in a different direction, would be my sense. Bart, what do you think of that answer? Does that make sense?
I think you answered that well. With my biggest fear in an ACO is that my patients are going outside of my network to providers who are going to not do a great job, going to raise my costs, and I have no control. So I think it's really important for an ACO to pick a partner that they believe in and trust, and work with that partner to keep the patients in the ACO and its network.
Yeah, that's been our experience as we've talked with people. I can share, not by name, but some of the ACOs that have come to us and said, hey, we're interested in a partnership, have said a couple of our patients got aligned by somebody else, and we got really concerned, because if a few can get aligned, then there's probably a way in which many more, right? And given that they drive 20% of total cost of care that you might be on the hook for, you certainly want to make sure that you understand who's managing those patients and what their capabilities are. Sam, are you out of questions? Do you have any more?
Yeah, no, we are wrapped up with questions for today. So I truly appreciate your presentation today. I know it was a very insightful one. Did you have anything else to add for your presentation today? I
want to answer one more question that we get asked frequently. That's okay, because I see we still have maybe another minute or two. One of the questions that's always asked is, how do you get people into the program? And John, you made the point that in these care management programs, enrollment is the key. And you've also shared with me that many times when vendors have promised you, hey, we can enroll people, you're kind of like a VC discounting revenue numbers. You cut it in half or something, right? So the ability to identify people with dementia and to identify their eligible caregivers from claims or other data is really critical to be successful. So this is a capability that is like when we work, I'll just say, when we work with a Medicare Advantage plan, we have no relationship with a provider, and you can totally imagine the plan would not be very capable of driving enrollment itself. So that's sort of where we cut our teeth in terms of being able to do enrollment. I think on the ACO side, what we can offer is an independent way to drive enrollment. I think over time, the PCPs will say, this is a really good program, and they'll proactively suggest it to people because they'll feel the unburdening. And they say, this is a great program. My caregivers of my patients are more educated. The visits are more effective, efficient. My care plans are being implemented. So I think the enrollment piece is really a huge piece of this. So this is not a referral model. This is one where Ceresti from claims data can take ownership of enrollment, drive people into the program, and of course, communicate who's in the program and whether they're engaged or not. So to me, the enrollment piece is huge. And one of the things that early on in the evolution of our company, we really said we have to get really good at. Okay, so Samantha, that was sort of my my self question, but again, we appreciate the opportunity to present sort of this view about dementia. Hopefully, this is something that maybe you can share with other folks. This will be taped and available. And I want to thank the panelists, Bart, John, Nicole. Fantastic discussion and conversation. So thank you. Have a terrific day.
Thank you.
Thanks, everybody.
Yeah, thank you.
Okay, bye-bye.
Bye. Have a great one.
Okay.